You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Today we are sitting down with Dr. Vinit Patel, author of a new article titled Non-medical Mephentermine Use, a systematic review of literature, currently featured in the November-December issue of the Journal of Addiction Medicine. Dr. Patel sits down to discuss what exactly mephentermine is, why and how it's currently being used in non-medical settings, specifically in India and South Asia, as well as some of the contributing factors associated with geographic disparities in non-medical mephentermine use. Dr. Vinit Patel is an assistant professor of psychiatry at All India Institute of Medical Sciences, India, with a clinical and research focus on addiction medicine. His work bridges clinical care and community research, focusing on opioid use disorders, behavioral addictions, and innovative treatment approaches, including take-home opioid agonist therapy and tele-addiction services. He has led studies on substance use in prisons, among heavy vehicle drivers, and in community-based opioid treatment programs, translating research insights into real-world clinical and public health practice. He has also contributed peer-reviewed papers, book chapters, and editorials on addiction epidemiology, drug policy, and harm reduction strategies in India. Dr. Patel is also certified by the International Society of Addiction Medicine and is the assistant editor for the Addiction Psychiatry Society of India newsletter. All right, now let's get into today's talk with Dr. Vinit Patel. First of all, I want to say thanks again for doing this and for doing an episode with us. It's really great to sit down and talk to you. I'm looking forward to our conversation. So, like I said, I'm gonna let you kind of take it away and start us off. I would love to know why this particular field. What was it about addiction medicine that caught your interest and made you want to pursue this particular path?
First of all, I would like to thank you so much for having me here, Jack. It's a real pleasure to be here and to join this, I guess, very important conversation. And I'm really excited to share some of our experiences from India and to reflect how addiction medicine is evolving in diverse settings like us. More than anything, I'm glad to be part of this wonderful discussion, and thank you again for inviting me. Coming to the main question that what led me to the field of addiction medicine. So, to be honest, what drew me initially to the addiction medicine was its unique balance between acute medical care and psychotherapeutic engagement. I believe addiction medicine is one of few branches of psychiatry where one can manage medical emergencies while simultaneously working at a psychological depth with patients and the families, which allowed me more of a rare sense of wholeness in my clinical practice. And as I continued working in this field, I was fortunate, to find mentors and colleagues who shared my perspective, deepened my understanding, as well as the commitment to the field. And this understanding evolved over the time through, getting experience to see a lot of cases, be it alcohol, opioid use disorders, also getting involved in community-based services, and later moving on to research on emerging stimulant use and hoping also to go to digital intervention and developing digital tools, to reach to the remote areas, especially in lower middle income countries or the low resource treatment setups. And what still continues to move me most is witnessing that how addiction is quietly and silently dismantling families, and how even within the healthcare system itself, stigma, moral judgment often overshadows the compassion the user deserve. So this combination of clinical challenge, with therapeutic meaning and systematic marginalization, I would rather say, is what makes addiction medicine not only very challenging, but also profoundly necessary as well, I would say. So this is to sum up what led me to the field of addiction and where I am.
It's amazing. Well, we're going to dive into your systematic review here and talk a little bit about something called mephentermine. And I want you to tell me a little bit more about it. Let's start with defining it. What is mephentermine, and why do some individuals use it in non-medical ways? And in that question, I wonder if you can also then talk about which groups in particular and individuals are at high risk for non-medical mephentermine use and dependence.
So to start with, what is mephentermine? So mephentermine is actually uh, a derivative of amphetamine groups, more specifically methylated phenethylamine, which means it's structurally more similar to methamphetamine. And when we talk about its pharmacological properties, it rather acts as a cardiac stimulant and works through a mix of both direct as well as indirect mechanisms. So, on one hand, it directly stimulates alpha and beta adrenergic receptors, particularly alpha 1 type. On other hand, it increases the release of norepinephrine, also facilitate the release of dopamine and serotonin. The combined effect of all this is a positive inotropic effect on the heart, leading to increase in cardiac output and increase in blood pressure, both systolic as well as diastolic. So once a person takes methamphetamine within their body, so inside the body, it gets metabolized much like any other amphetamine group derivatives. So first, it gets demethylated to something called as phentermine, which is an active metabolite, and it's often detected in the urine sample of the users who take mephentermine uh, for medical as well as non-medical use. And in turn, it inhibits two enzymes called monoamine oxidase A and B, which raises the brain level of neurotransmitter, which are monotriaminergic neurotransmitters like noradrenaline, dopamine, and serotonin. Eventually, these are the ones which cause a feeling of euphoria, stimulating effects which people perceive after taking the drug. It can also undergo demethylation to something called as amphetamine itself. And as we all know, amphetamine adds another angle of stimulant and the psychosis related component when people use amphetamine uh, for their uh, purpose. So, uh, adding another stimulant angle and psychosis related component after use of methamphetamine. When we talk about the routes, the most common route which has been reported in the literature or what we have seen in our clinical experience is intravenous. But how also people after sometimes they are not able to coordinate, and literature also reports medical use in an intramuscular route. The only difference is the intramuscular route acts a bit slowly within 5 to 10 minutes and lasts for a couple of hours, almost 4 hours or so. Whereas intravenous route acts almost instantaneously and lasts only for 30 minutes and ends up very for shorter duration. So this is in all about what is methamphetamine and how does it act. Coming to the second part about why people use it for non-medical reason, I would rather talk about medical uses first. Why people, what is the indication for which methamphetamine has been licensed or approved, and then I'll come to the non-medical use part. So medically, mephentermine has been approved in India as a hypertensive agent, mainly used for short-term management of hypotensions, for example, during a shock or during a myocardial infarction, uh, during perioperative procedure like during spinal anesthesia or cesarean section. It's in India, it is available in a for liquid formulation for parenteral use, be it intravenous or be it intramuscular, in a dosing strength of mostly 30 milligrams per milliliter, but also available in 15. And the other routes or other use are also been mentioned. Like historically, it used to be marketed in USA as a nasal decongestant. But however, since then it has been taken out of the market. In fact, they have altogether banned it or discontinued it for the human use at all. As far as central nervous system effect is concerned, even though CNS effect of mephentermine is not as strong as other amphetamine or classical amphetamine groups, it does have some CNS property because of its metabolite being phentermine and uh, amphetamine metabolites we discussed previously. Also, the increased level of monoaminergic transmission, it causes increase in alertness. It increases the mood. It elevates. It also causes feeling of euphoria as reported by the patients. Now, after this, coming to the real question, why mephentermine is being used non-medically. So, over the past few years, we have seen non-medical use of mephentermine emerging as a public health issues, especially in India and some other countries of Southeast Asia. Initially, it appeared that it has restricted to professional competitive athletes who are either involved in a performance sport or any contact sports. But later, recently, we have been finding that it has now extended to a regular gym goer population, a fitness enthusiast, any manual labor or worker, even young professionals, students, with an expectation to boost their stamina, alertness, so that they'll be able to focus more on studies or will be able to do longer amount, duration of work with the same attentiveness. And also in few case reports cases, users told us that they just wanted to enjoy, feel good about it. So we did get some angle of euphoria as far as use of methamphetamine is concerned. Several factors make it very particular option or very attractive option for non-medical use. So one is its availability. So when I say its availability, it is often sold over the counter in local pharmacies here, or sometimes even by gym trainers being offered to the people who are preparing or training themselves under them. And largely, almost every single case or individual told us that they did not require a prescription, although it is categorized within our country as prescription only medicine. So that is one, that it is being easily accessible or available in the environment. Second is its perception by the user that it is safer than other performance enhancing drugs, being anabolic steroids or other hormonal replacement, which are also more common in the same cohort and which are major deterrent in terms of those drugs causing sexual dysfunction. And that is the most common deterrent among young men who are again more prevalent for gym enthusiasts, right? The third and another reason is user sometimes have described that subjective benefits like increased energy, endurance, alertness, focus, and sometimes even sense of relaxation and increase in their confidence to address day-to-day activities. And all these, they in many of the scenarios they labeled is getting high without appearing intoxicated visibly. So, in a way, it gave them a bypass for criticism or moral judgment or any stigma associated with using any substance, right? So that was another angle for which individuals reported us. There are also only few reports where people report told us that uh, they used to take it in combination with other substances, mainly opioids, because after taking opioids, sometimes they said they feel weak. So we try to understand it is after taking IV opioid, the drowsiness or the weakness or the sedation gets revert with you combining it with fentanyl. That's what we were able to understand and made sense out of it. In our own observation, uh, almost 80% of all the reported cases, people used it in intravenous route. They went up to a dose as high as almost 12 to 1500 milligrams a day, compared to a therapeutic range of only 60 milligrams a day maximum. So this is what the level of non-medical use of amphetamine has been there. And other routes which have been reported very clearly are intramuscular and nasal, using nasal spray, like we talked about. Coming to the last part, high risk groups and demographic profile. So, in our systematic review, also in one of our case series where we reported 12 cases of methylphentermine user within a short span of 3 months. So, we started seeing that very frequently now in our clinical setup. They were young males between 20 to 40 years. Most of them were athletes, mainly gym goers. Few of them were professional bodybuilders or professional weightlifter. Many of them were involved in contact sports, and strikingly, many of them were also preparing for recruitment in one of the forces, be it police, be it army. So the physical requirement to get passed through there, that also was one of the reason. We also did see some of the working professional, some of the students procuring it easily and using it to improve their performances. So overall, mephentermine, as per us, sits at a very unique intersection. A prescription cardiac drug with amphetamine-like properties, available through a very loosely regulated legal channels, and repurposed for performance enhancement in absence of a more strict surveillance system, I would say. So that is what it's all about. This.
I've got to ask now, and you touched on this a little bit. You mentioned the fact that this was available in the U.S. for a while, and it's since been banned. You mentioned that in a place there like India, you don't need a prescription; you can get it over the counter. So I wonder, the majority of documented mephentermine cases seem to emerge from India and South Asia. So I wonder if you can share what are some of the potential contributing factors for geographic disparities in non-medical mephentermine use.
Talking about our systematic review, in our systematic review and subsequent case series, which I'm talking about, revealed a very clear geographical clustering of non-medical mephentermine use, with almost more than 90% of the reported cases till date, and almost all of the treatment-seeking cases in our cohort did originate from within India, and couple of cases were within other parts of the Southeast Asia. This pattern provides the first of its kind and first empirical evidence, I would say, that stimulant misuse or stimulant use in South Asia may be driven more by contextual factors than pharmacological factors. What do we mean by this is, in our data, ease of access emerged as a major determinant. Nearly half of the user uh, procured the drug directly from a local chemist or without prescription, and another quarter did from their gym trainers, despite them being a regulated medication. This pattern reflects regulatory laxity and limited reinforcement rather than clinical demand alone per se. That demand itself cannot be the sole driver. What's particularly interesting is that use does not rely on illegal supply of chain, unlike other stimulants, where the procurement source has to be almost absolutely illegal means only. In our data, mephentermine moved entirely within the legal pharmaceutical channels. Uh, Although intermediate either can be a chemist shop or can be a gym trainer, but within the legal means. So it's rather a public health blind spot because it's neither trafficked nor smuggled. That makes it very difficult, to even monitor, since it falls outside a conventional narcotic control framework within India, and very uh, challenging to monitor it. In contrast, the methamphetamine has been discontinued for human use in most of the countries, and now largely restricted to veterinary medicine in regions like Brazil, and stronger, and other reason being availability of stronger stimulants, different or alternate performance enhancing drugs like anabolic steroids, methamphetamine, and other amphetamine formulations remains more common options in high income countries where mephentermine use has been banned altogether for human consumption. Another equally striking factor is the economic dimension. I mean, we do have to talk about economics when we, talk about any of the substances, psychoactive substances. So when we talk about the cost, with in our study and also in the case series which we published, the median retail price per unit was around $3. Mephentermine functioning as a low cost stimulant substitute, at least within South and Southeast Asia, especially among young men rising or hailing from more lower income backgrounds. In India's market, where access is to other stimulants like amphetamine and imported anabolic steroids is very limited, or even if it's available, being very costly, it offers an affordable and more easily available alternative and substituting or almost meeting the stimulant niche. Another angle is the social environment also, which amplifies this pattern. Uh, what do I mean? This in over the years, over the decades, the rise in the fitness culture, rise in performance-oriented substance use, coupled with limited anti-doping surveillance, uh, especially in local tournaments, or limitation of technologies or doping equipments to detect use of mephentermine. This creates almost unsaid permissive ecosystem for continued using mephentermine to increase the performance. And meanwhile, under recognition in rest of the global research, in rest of the part of the world, has also been contributed knowingly or unknowingly, partly, in this entire phenomena of mephentermine rising only towards South or Southeast Asia. So that has to be addressed as well, because there are other bigger issues for the West or the other part of the world to focus on. So a couple of here and there becomes very challenging. And together, all these findings suggest that mephentermine use is less a pharmacological anomaly and more of a product of regulatory, economical, or socio-cultural system. And it exemplifies how the global South can serve as an early signal, for an emerging stimulant uh, uh, rather than more uh, more stigmatizing approach. What do you mean? It can, I mean, it what do I mean to say here is that this pattern of rising mephentermine use in global South can serve as an early signal for emerging stimulant use before they attract attention in the Western context. So it can prepare us as a precautionary measure or as an early signal, rather than us to discard it, saying that it is a regional problem and world need not to focus on it.
I wonder too, at the moment, there's not an established protocol for treating mephenamine dependence. So, what do you see as some treatment options for, particularly for mephenamine dependence that you're seeing now?
And I thank you, Zach, for bringing up this very important question. And actually, one of our major finding from our research was that there are currently no standardized or evidence-based treatment protocols developed specifically for mephentermine dependence. Not there are any guidelines or even guidance. So globally, the literature is extremely limited, as we already discussed, mostly just isolated case reports, case series. And what we have seen so far is that management almost always is symptomatic. modeled on how clinicians handle amphetamine type of stimulants, their use in general. So, for example, these reports mention the use of benzodiazepines for agitation, restlessness, or withdrawal symptoms, which occur after cessation of mephentermine use, and sometimes use of different antipsychotic medications for intoxication related psychosis or paranoia. uh, Usually we tend to avoid using antipsychotic medication for intoxication related psychosis because the dictum goes that after the cessation of the drug it will take care of itself and then subside. But in clinic what we saw, the severity of psychotic symptoms were so much that we need to intervene. To give you a couple of example, one of the patient came with a severe laceration of his finger. So he was having the psychotic symptoms that this finger is not his, and he wanted to cut it off. And it was severely lacerated. We had to first care the local wound, and so that is the severity of the psychotic symptoms and conviction patient turned out with. So we did address those symptoms. We had to start antipsychotic along with benzodiazepine in couple of cases. In many of those cases, once the person stops using mephentermine, the symptom usually subsides, tend to resolve within a couple of weeks, at least within a month or so. There are, although few mentions of other agents like bupropion, mirtazapine, naltrexone, baclofen as well, being used to help with the craving or mood stabilization. But none of this medication have been studied systematically or in controlled setup in controlled trials. So the mainstay of treatment remains psychological intervention, like in the lines of cognitive behavioral therapies or relapse prevention therapy or motivational enhancement therapy, or a structured psychoeducation session itself uh, tend to play some role. In our systematic review, roughly around 30 cases, we confirmed that there is hardly any mention of the treatment being provided or the rationale behind it. There are multiple reasons to that. That is not the purview of this podcast, but most of the treatment, if we want to sum up the take home point, so most of the management was supportive in almost all the cases. The recovery largely dependent on abstinence, and the main focus was short term stabilization of symptoms. When we looked at our own case series where we reported 12 consecutive patients who came to us in our setup, so our treatment facility, addiction treatment facility, is a tertiary addiction center located in India. So we saw that treatment provided by the clinician or the treatment providers were completely symptom driven, reflecting what real world practice looks like. Almost about 40 to 45% received antipsychotic medication, and the most common being olanzapine. Doses differ, and almost 60% were given benzodiazepine medication, be it shorter acting like lorazepam or longer acting like diazepam, for their restlessness and insomnia complaints. And about one third of them received bupropion. However, in our scenario, the bupropion use were more in terms of because comorbid nicotine dependence was also present in these cases, and uh, we wanted that also to be addressed, so that give us leeway. However, in our case, because of very strong craving for mephentermine, the patient was prescribed bupropion as an replacement therapy off label. The bupropion was interesting because it acts both on dopamine and norepinephrine pathways, and this is the only drug because large majority of our populations are professional athletes. So World Anti-Doping Association permissible list the bupropion is the only medication which is allowed as far as the stimulant category is concerned, meaning it is a practical option for athlete and fitness professionals who cannot take other regulated or other banned substances in even in the form of medication. Another angle is supportive care, like treating the injection site infections, managing associated hypertension, helping the patients with their sleep problems were another treatment interventions which were provided to the cases. However, most of these patients did not needed a long-term inpatient care. Majority of them improved within a couple of weeks of abstinence from mephentermine, associated with the structured outpatient follow-up post-discharge. So, clinically, we also noticed that this patient presented quite differently from what we usually see in other stimulants like methamphetamine or cocaine or amphetamine users. Many of amphetamine users were working. You can label it as a job, you can label it as a exercising for their profession, for their sport, right until medical or psychiatric symptoms became very severe. Till that time, despite using the mephentermine, they were functional. The main complications weren't social collapse or chaotic use like in other stimulants, which are very harmful also in those terms, but physical symptoms like hypertension, injection site infection, brief intoxication related psychosis, they were the main reason for treatment seeking either by patient or by the family members. And again, they quickly resolve within couple of weeks or within a month at least after abstinence. So this looked almost like a distinct clinical phenotype, one that called for a different kind of early intervention, different outpatient-based care treatment approach than other classical stimulant group. And from our experience, methylphenidate dependence really represents uh, early phase of stimulant use pattern for which the current guidelines are lacking, or rather, I would say they just don't exist yet. And in practice, we have found that combining short-term pharmacological stabilization with the benzodiazepine, antipsychotics, sometimes bupropion, and behavioral interventions works quite well for shorter term. But clearly, there's a very urgent need for systematic clinical trials to evaluate both medication as well as psychosocial interventions, specifically tailored for mephentermine within stimulants emerging in Indian or broader South Asian contexts.
Well, to springboard off of what you just mentioned there about some of these future things that are needed, tell me a little bit about, in this systematic review, what kind of future research questions emerged, and what kind of studies do you think might be able to address those questions that came up?
The future uh, angle, or that is the question in many ways where our work really stands out. So, globally, research on mephentermine is extremely limited, very limited. I mean, recently, hardly any cases have been reported outside South Asian context. Most of what's available are isolated case reports or brief letter to the editors or a case series at max. There are no epidemiological study, no neurobehavioral biological investigation, no clinical trials assessing its addiction potential, treatment outcomes, or long-term trajectory of use as well. Unlike other amphetamine types of stimulants, if we let's categorize it under ATS, unlike other amphetamine type stimulants, it hasn't been systematically studied either in animal models or human laboratory settings. So we really don't know how it behaves in terms of reinforcement properties, how dose dependent toxicity works, or what are the dependent trajectory it leads to. So this lack of structured research has created big gaps in diagnostic clarity, pharmacotherapeutic evaluation, and even surveillance and monitoring, especially in setups which are resource constant or in low and middle income countries where stimulant misuse patterns are changing very rapidly. So, in our systematic review, the it is first global synthesis of its kind. We identified 30 published cases of non-medical use, and uh, the reports were inconsistent. What do I mean by that? We did not find a single template or common complaints or common variables reported by them. Many did not include details like dosages or for how long person is using mephentermine, what were the complications which were reported for which they sought treatment. So it became clear that we need standardized case documentation first of all, and active surveillance systems for stimulant misuse comes later. So then, in our consecutive case series, as a result of review, uh, we reported 12 treatment-seeking individual at our centers. We were able to describe their pattern more systematically. All were young males using intravenously and primarily for performance enhancement. So from this data, several key research priorities emerge. So first is we need to understand prevalence and patterns, that how common is phentermine use really in the community. That means large cross-sectional studies among high-risk population like fitness enthusiasts, or at least gym goers or professional athletes are required to map early use, early trends. Second, we need to study addiction liabilities and neurobiological effects of mephentermine. Many of our patients reported euphoria, tolerance, and withdrawal. Very striking was euphoria. So, in most of the substance, the expectation when is met, people grow out of it. Here, the expectation was increase in performance. Many of them, although they stopped competing in the professional sports, they stopped preparing for the, let's say, getting selected in forces. Despite that, they continued using it, and almost 10% of them reported that we feel good after using it. Although for an hour or so, we just feel good. It doesn't matter what was the expectation earlier. So that is very typical of any psychoactive substance. So here we are lacking psychoactive, addiction liability studies for mephentermine. Although they exist for phentermine, but mephentermine there are none. So that is second. The third is there is issue of all long-term health consequences. In terms of long-term health consequences, we with respect to mephentermine, most of the literature only points out to cardiac effects, which are secondary to the increasing blood pressure on long term. Beyond that, very rare any physiological or physical changes are documented. So there's the issue of long-term health consequences which need to be studied. And fourth and the last, we definitely need urgent clinical trials, both pharmacological as well as psychological at the moment, because the current management entirely depends only on symptomatic relief rather than long-term treatment. So trial testing bupropion, naltrexone, or any combination with the psychosocial intervention could really build the evidence base for treatment options. And finally, we cannot ignore more social issues or gender dimensions. Like every documented cases so far involves young men driven by body image or performance expectations, and so qualitative studies, or rather mixed method studies, exploring their understanding with respect to body image or their expectation with respect to performance, not just in a competitive sport, just uh, as a fitness enthusiast. Why does that plays such a strong role, and in the entire gym culture in Southeast Asia or South Asia could also add a very important context to the subject. So broadly, our takeaway is that mephentermine is a neglected but a very emerging stimulant of concern. And research now needs to move to descriptive work to systematic inquiry. Till now, we are just describing this many percentages and this many cases. Now we need to go a bit more systematic, mapping prevalences, exploring treatment, and developing public health strategies. Mainly fitting for resource constrained settings. And and one very important point that if we zoom out and see it on a larger scale, there are also a global warning embedded in this story. The pattern we are seeing here with mephentermine in India and Southeast Asia looks very similar to earlier trajectories which we had been seeing. You talk about history of tramadol, you talk about rising issues of tapentadol misuse, you talk about codeine cough syrup, you talk about use of buprenorphine tablet diverted as injecting route, or you talk about synthetic cathinones. All of these first appeared in a low regulated setup with high availability before spreading internationally. And as both WHO and UNODC have pointed out, South Asia's combination of large pharmaceutical manufacturing capacity and uneven regulatory enforcement and growing youth market makes it a perfect incubator for new psychoactive substances. And mephentermine, I guess, fits this pattern almost perfectly. So, in many ways, we are observing what we are observing in India could serve as an early warning for other regions, and it underscores the need for regional surveillance, uh, data sharing within institution, within bodies, and proactive policy measures before this becomes a broader global public health problem.
Yeah. So, Dr. Patel, it's been a really interesting and awesome conversation. I want to thank you for that, first of all. But you shared so much information and wisdom already. I want to shift gears a little bit as we close out our episode and ask you for just a little bit more advice and wisdom. And that would be, what kind of advice and wisdom would you personally impart onto the up and coming generation of addiction medicine professionals who may be just entering the field or just getting interested in the field? What do you wish you knew when you started, and what information do you think is good for those individuals to know getting into this area of practice?
That's the toughest one, I guess. So, if I were to, or if I can at all offer advice to, I would say, my younger self or to the next generation entering into addiction medicine, it would be this: let the curiosity remain as strong as your compassion. So, addiction medicine is a field that keeps continuously evolving, and it is very precisely sitting at the intersection of biology, behavior, and society. And the most meaningful progress comes when we question patterns that seem very familiar but are not yet understood. So I can draw parallel from our work on mephentermine use. It began not from a large data set, but from a clinical curiosity, observing a pattern that seemed very unusual among young men attending to our clinic, and pursuing it with with a scientific approach, more a systematic rigor, until it revealed a new public health concern. So this entire experience reinforced a lesson on me that every local observation has the potential to become a global insight, right? So if studied carefully. So the next generation should cultivate this ability and try to combine clinical acumen with data-driven inquiry, and to see research as a tool for service, not as a prestige. So I would also remind them that even after linking it to service, the advocacy is very integral part to science, and especially in the population to which we serve in addiction medicine is in very dire need for a strong advocacy. So, finally, addiction medicine demands patience and perspective, and Outcomes are rarely immediate, and success is often measured not in cures, but in continuity, in dignity, and incremental recovery, I would say. So, that would be my advice. And to thrive in this field is to find a balance in science of neurobiology and humanity of care.
I love it. Dr. Patel, thank you so much for taking the time to sit down and talk with me today. It's been fantastic.
Thank you so much. And I literally would like to thank you once again for having me here. It's been a privilege to share our experience and perspective from India. And as addiction medicine is constantly reminding us that science and empathy must go hand in hand, I also want to take a moment here to acknowledge my mentors, many of whom have played very pivotal role in my career, in my approach, in my learning, in my treating. Uh, Specifically, I would like to acknowledge Professor Ravindra Rao, whose mentorship and guidance have profoundly shaped the way I approach this field, both as a clinician, as a researcher, also as a person. I hope this conversation like this continues to build, knowledge or understanding across the region, helping us to move towards the care which is based both in evidence and deeply human. Thank you, Zach. Thanks for the experience.
Can't think of a better way to wrap it up. Thank you so much. This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.